This next class of drugs are deemed muscle relaxers and combination therapy, and they're pretty representative of some of the drugs that you see in the CNS where they don't really fit in a specific basket, and that's because they share some chemistry with various drugs um, from other diseases and from other indications. One of which we've already talked about. We've already mentioned cyclobenzaprine. We had talked about this drug in the movement and mechanics block, specifically in the context of lower back pain. This drug, it has the ability to increase norepinephrine within the spinal cord, and it also inhibits lower motor neuron activity. From a mechanistic standpoint, or from a structural standpoint, I should say, this drug is benzodiazepine-like, and we'll talk at length about benzodiazepines through the second half of this curriculum. They're really kind of the steroids of the CNS block. You know how often we use steroids in previous blocks for seemingly random diseases. Benzodiazepines are kind of the go-to drug for many diseases, neurological. So cyclobenzaprine has some structural similarity with the benzodiazepines, which we'll spend a lot of time on. The side effects are really reminiscent of another group of drugs that we're going to talk at length about during depression, and that are the tricyclic antidepressants. And amitriptyline is kind of the grandparent molecule, which is shown on the right. And it shares some of the main side effects with amitriptyline: drowsiness, sedation, and dry mouth. Okay. And so officially, this drug can be classified as a muscle relaxer, and it has clinical use and efficacy in the treatment of various types of headaches. Other combination therapies that contain components of muscle relaxers include the brand name formulation Fiorinol, which is a combination aspirin, so you get your NSAID, butalbital, which is a muscle relaxer, and caffeine. And then another combination, which a lot of patients are quite fond of, is Midrin, which is a combination of acetaminophen, dichlorphenazine, can never say that one, and isometheptane. Okay, and so basically what you do is you have several different combinations out there that basically produce muscle relaxation as well as an inhibition of the COX pathway through the use of NSAIDs. The next group of drugs are the Ergot Alkaloids, and the prototype here is ergotamine. And these are historically really interesting, and so we think these were kind of the causative agents of the mass hysteria and the rather odd psychiatric behavior of the Salem witch trials, which occurred in Boston in the 16th and 17th century. And we think it's really due to wheat and grain storage being contaminated by this particular fungus. And so when this fungus basically sprouts on dampened or improperly stored grains, which historically may have happened in Salem at that time, you get this disease phenotype called ergotamine. And of course, you know, we have young children, so anytime we talk about witches, we talk about the great movie Hocus Pocus. If you've never seen it, it's a great movie. I've watched it 15 times last October. So ergotamine is one of these drugs that has kind of mixed activity, and so this is really kind of a mixed partial agonist at various serotonin receptors as well as the adrenaline receptors, alpha and beta receptors. And so what we see is we can see a direct vasoconstriction in atonic vessels within the CNS, and the derivatives of ergotamine have been used as adjuvants in other diseases, which we haven't covered just yet. But it's really important to differentiate the ergotamine alkaloids in terms of, you know, kind of acute versus chronic side effects. And you know, the acute effects can be as benign as nausea and vomiting, swollen fingers, leg cramps, but they can also lead into more serious side effects: confusion, myocardial infarction, tremor, and so forth. And so as the amount of ergotamine kind of gets incorporated into the system, you can see hallucinations, nausea, ischemic changes, column lesions within the spinal cord, depression. These are all kind of the hallmarks of long-term chronic ergot alkaline poisoning. And so this basically just summarizes the main points. I think we can now kind of get into the treatment approaches. And so how do you treat headache? Well, the treatment of headache, of a headache in progress, or a mild to moderate headache that has low occurrence, can really be treated by several drugs. But if you've got a migraine, we're really looking at OTC NSAIDs. If you've got a tension headache, we're looking at OTC NSAIDs as well. Cluster headaches, basically you can use ergots or triptans. And so each of these drugs has their benefits and their weaknesses, of course. And then the next slide kind of looks at different treatment approaches at prevention or prophylaxis. And so there's several drug categories, drug classes that can be used to prevent migraine. So anticonvulsants, we're going to table those and save those for another case. You know how calcium channel blockers and beta blockers work. We'll spend some time on amitriptyline later in the curriculum when we talk about depression. Tension headaches, muscle relaxers, and amitriptyline work great. Cluster headaches have been really kind of well prevented with the use of persistent calcium channel blockers. Okay, so these are kind of the treatment modalities that exist for migraine. I do want to draw your attention to the last slide. This was, I just made this today, and this is based on a recent group of drugs that just received FDA approval in March or February of 2018. And these are the CGRP blockers. These are calcitonin gene-related peptide blockers. And so this particular peptide is well known to be released during migraine and cluster headaches, and it seems to play a major role in the pathogenesis of migraine. It's associated with activity at the trigeminal ganglionic neuron, and it's associated with the production of kind of pro-inflammatory cytokines that govern its release but also kind of persist into the disease. These CGRP blockers are monoclonal antibody in nature, and the two formulations or the two types are listed there. And I'm not going to test you on this. Of course, this is something that's new that just came out, but I think it's good to know because it seems like it's going to be a game changer for how we can treat migraine, because those drugs are, outside of the triptans, those other drugs in those categories are not pleasant and have their own side effect profile that really doesn't really contribute to the lifestyle of the migraineur. So these drugs, as good as they sound, are very costly, but it's going to be a pivotal way in which we can treat migraine. So I just want you to know that they exist. And like all things, immunology is kind of taking over pharmacology. And so these are, again, these kind of targeted therapy. These are monoclonal antibodies that shut down a specific key receptor that's known to be pathogenic. So interesting group of drugs. You'll hear more about them in the next year or two. So that's it for the pharmacology for migraine and headache. And so again, if you have any questions, please let me know. And I hope the block is going well for you. Thank you.